Uh,
You too. Dr. Jagbe, what did you say?
well, I was just gonna say that's not where it's starting from.
It's all right.
So
It's all right. We're
okay.
starting.
Uh,
He can do as he pleases. Dr. Jagbe, what did you say? Good evening, everyone, and welcome to Medical Mondays with Dr. O. Wow. Welcome. Tony Okwesomi, I'm a physician, family practitioner, HIV specialist, and I treat addictions in Maryland. I enjoy learning and, also imparting to prevent health, health issues, health problems, diseases and entities. And so that's why we have Medical Mondays with Dr. O. Last week, we had Dr. Ravendra, who came to talk to us about fatty liver, which, as we all have learned, I hope that it's a new epidemic and it's something we need to guard against with lifestyle changes and also with exercises. So that being said, we felt it was important to follow up that important subject last week with some exercises that are focused on the heart, that's cardiovascular strengthening and musculoskeletal. What I learned actually here on Medical Mondays a while back is that physical therapy is not just for musculoskeletal issues when somebody's in an accident or have back pain and stuff like that. But there are many other things that physical therapists specialize in, like in the heart, cardiovascular, as I just said, strengthening and stuff like that. So we are privileged to have one of our very own, Dr. Olatunji Popoola, who is a doctor of physical therapy and has agreed to come and show us some exercises as well as some encouragement in how to better our health and how to incorporate exercises into our lifestyle. So I'm going to yield the floor to Dr. Popoola. The floor is now yours and welcome. Thank you for doing this.
Yeah, good evening, ladies and gentlemen, my very senior colleagues, erudite scholars, and if I may borrow a word from one of our good friends, Dr. Luya, who says people like you and him as a medical advocate, in which case advocating for the appropriateness, effectiveness, and accessibility of medical services to people of particular demography, and I don't want to say racial, but certainly just people who are underrepresented. And when it comes to health and ill health, human beings, we're all the same. I was faced with an issue when I came over from Nigeria a few years back, and somebody was interested in what I was doing. And I said, human beings are not different. What we carry in our body is not different. And health and disease circumstances or conditions is identical with us all. However, there's still something amiss. I will relate to it, I will access it. So to quickly move forward on this, there was that situation too. And one of the patients that I was supposed to treat, sincerely speaking, it is something Jewish lady, and some was a rabbi, very big one of the biggest 5 in the world, as I like. And I had the privilege to treat her, and in the process, the back pain she complained of, and I said, "Can I see your back?" And I asked the lady who was there were 2 of them who were with her, and I said, "I'm going to step aside, drape the patient." That's the word we use. Drape the patient means only expose the area we want to treat or want to examine. And when to examine multiple places, we drape adjacent places so that we can go systematically from one point to the other. By the time I got back to my office, when I was working in an agency, my spouse called me and said, "How did you ask that they should undress an elderly Jewish lady, the mom of a rabbi?" And I said, "No, I did not undress her. I told the chaperone to do it, and I stepped out of the room." Okay, then I came back and did the examination. Lo and behold, she was having a charcot spine, tuberculosis of the spine. So I said, and I called the doctor that, look, this is not just low back pain from a sprain or strain. Okay, I could see a gibbous, another thing. He exclaimed. Okay, so there are so many circumstances of that we as clients of patients and as practitioners will get the lower end of the rod. So when we now say that we that I'm saying is referring to now, what we are going to go to our topic of the day is how we are going to let us improve our cardiovascular and endurance strength, or our musculoskeletal mobility and endurance strength, and our physical performance. Okay, that is our functional capacity. The bottom line is that as we get older, it's almost the rule that limitations will start occurring. Okay, and those limitations often culminate in degenerative disease conditions. Okay, and sometimes too, any other disease can come on. Diabetes is always closer to us. Okay, coronary artery diseases, congestive heart failure, and all these conditions that have to do with lifestyle and mobility. So my first sentence to say, to get this rolling, is that movement is perhaps the most important aspect of living pains, which we'll start learning from 4th grade. What are the characteristics of living pain? Every single organism moves. And without movement, you are not going to not just be able to perform activities, your state of health is going to decline. Okay, and movement at the person level, movement at the systemic level, at the what do you call it, and all the way to the cellular level. Let me put it that way. It's essential. Everything moves, and once there's no movement, then there is absolutely no life. Everything moves. Okay, so the most important thing now we are looking at as we get older, then we start declining movements. We start reducing our mobility. We start finding ourselves caught up in that cycle of joint pains, of just of breathlessness, difficulty to do certain things, which is the tool we do when we're younger. The only thing some people amongst us can do better when they get older, they can talk more, and they can have more money from their investment. Outside that, every other thing goes down as we get to 50 years and above. Ladies and gentlemen, I think the first thing to look at what's the cardiovascular system. What are we talking about? The cardiovascular system involves the heart, okay, and the blood vessels, that is the heart and circulation. Okay, it is so important to the body because it takes life to every aspect of the body. when there's no adequacy of circulation to any tissue or organ, then the tissue fails to perform and will start dying. And gradually, from ischemia all the way to the time when it becomes completely degenerate. Now, blood has to reach every area of the body, and blood have to leave every area of the body. That is circulation. That the blood gets there, new blood, fresh blood gets there, arterial blood, and venous blood leaves with the waste products, and it gets to the lungs, and then the lungs excrete some of the carbon dioxide and carbon monoxide and every other thing can excrete, then gets it back to circulation. Every other organ now plays their part, the kidney, the liver, in getting something done with the blood, okay, the nutrients, the nutrient extract, and whatever product they're going to put in the blood to impact and influence the body. So it's so important that to keep this system healthy, will keep the entire body healthy. Now there's cardiovascular fitness. How efficient could it be? And what are those things that will limit it? I have in what could have been my first slide, a list of disease conditions that involves the cardiovascular system that we have to take cognizance of. Many times we may not remember many of this is as easy to start experiencing. Usually you don't actually even know when it starts coming in. Okay, we have the rheumatic heart diseases. And rheumatism only talks about connective tissue that are supposed to be packaging for the body, that are supposed to facilitate what do you call it, transmission of impulses across certain areas, and also to clear waste, and also what we don't think about so much, facilitate the functioning of every other organ. So rheumatic diseases will affect any area of the body, because it's all over the body where you have connective tissue to support every organ and tissue in the body. And we have the hypertensive diseases. I'm going to jump on that very quickly. Hypertension just says your blood pressure is higher than is expected for your characteristic, than the standard for your gender, for your age, etc. But the funny thing is that in a study which I participated in, we found out that a lot of people go around with blood pressure of as much as 200 over 100 and even more for years without feeling uncomfortable. And for about 8 years to 10 years, I was carrying a BP of 160 to 180 over 90 to 120. And I felt normal. And I remember I went for an event, and one of our senior doctor, Dr. Obilo, he said, Dr. Poppy, I'm going to put you right in the off. And I said, I came here so that I can get the blood pressure down. So that is what I want to talk about. I went to a parade. I went to a function so that I could get my blood pressure down. Okay, isn't that interesting? Others will have said, okay, you should be on bed rest. And I said, no, I'm not going to go on bed rest. I've been carrying this around for quite a while. And every time I go out and play some sports, even though I'm not a good dancer, I just go to look at people dancing, my blood pressure comes down a little bit. Okay, then it goes back up. So these are circumstances. And recently, we had a group of about 50 men, able men, ill and earthy. They went for their old students association, and we told them before coming, please take your blood pressure for about 3 weeks before, or 1 month before the event, and we'll see the average. Then come and enjoy the atmosphere for 2 or 3 days and play cricket and play golf, and let's see what happens after about 1 month after coming for the event. most of them confirmed that their blood pressure went down following just 2 days of moving outdoor activities, okay? And at the end of the day, it remains better for at least 2 to 3 weeks and up to 4 weeks when we review the data. So this is where we are coming to. This was what actually created this lecture. That was what we were discussing. And I'm going to also spend 1 minute into that before I move into other conditions. We have the ischemic heart diseases. And that means ischemia means enough blood is not reaching any area of tissue. And that tissue is actually struggling to use the amount of blood that is got. So it's going to start reducing its activity, pain will set in, okay? And if that is not reversed, then other things will start coming down. And ischemic heart diseases is one of the most conditions that we normally face under COAD, coronary artery diseases, which affects the muscles of the heart. I'm going to talk about briefly too. Then we have the cerebrovascular diseases.
Exercise.
And yes, please?
I said exercise. I want to remind you of the exercise.
Yeah, we're going to do some exercise here. Just to let's see the spectrum of how exercise could impact respective systems. Okay? So we have the cerebrovascular condition, that is the cerebrum, which is the brain, and the blood flow, blood supply to the brain. Do you know exercise affects your brain? Improves your attentiveness, improves and actually helps in reducing all the plaques that form in the brain. And also, of course, impacted by the hormone that the brain centers releases. And so we're going to talk about that briefly if we have some time during the question and answer. Of course, you have the disease of the peripheral vascular system, where you have the veins, the lymphatic vessels, the lymph nodes, and etc. Essentially, I'm going to put all of this under one, the muscle pump. When your heart pumps, your heart is a chunk of muscle that has 4 chambers and have valves, okay? And electrical activities makes the heart to synchronously move blood from one chamber to the other into the lungs and into the systemic circulation. So when we think about it, the heart pumps the blood all the way out and it gets to the distal toe. But the blood has to come back to the heart to keep the circulation. There cannot be a break in it. There must not be a break in it, actually. Otherwise, we start having Ebola and other things which are catastrophic. So what makes the blood go back? The most important that makes the blood go back to the heart for recirculation, to keep circulation going, is what we call the muscle pump. That is, the peripheral muscles, as they contract and relax, they serve as an accessory pump to support the cardiovascular system to move blood circulation into different organs, into the system and organs and tissues, and also keep circulation going. So when you start having the swollen legs and all the other things, before it becomes too difficult, what we are talking about is that when you're able to let your muscles contract and relax, we'll talk about that. That rhythm, the synchrony of contract, relax, is essentially the pulse of life. And your muscles don't actually stop pulsating, that is, contracting and relaxing, at any point in time, even when you are sleeping. They have to still remain in a state of tone, whereby they contract and relax to keep blood moving, to keep lymph moving. And whenever you have any limitation of all of this and the disease condition begins, okay, whether it's cellulitis at the end of the day, whether it's edema, your most effective treatment is to activate the muscle pump. There is no brainer in it. Otherwise, the blood doesn't return to the heart enough. Instead, forward failure, backward failure, these are the terminologies we used to use. But that terminology actually makes it easier to explain that phenomenon. That if no blood is not returning, because you don't have the peripheral support of the muscle pump moving blood forward. Okay, or when you have obstruction to that blood getting back, okay, you have the backward failure. So you start having heart failure. So you can control and correct most of these things just by doing adequate and appropriate movement. As we said, as we get older, sometimes we lose sight of the need to move. And I normally tell people when the physical therapy comes to the bedside, it is time of a patient. It is time to move. When you come to the physical therapy clinic, okay, for any kind of ailment, sincerely speaking, we make sure we induce movement. Any aspect of treatment we do, we override with movement. When you take your medication, for your medication to be effective in any area of the body, we have to induce movement. Movement is actually the tonic of life. Okay. Now, we'll quickly jump into the musculoskeletal system, which is also what we are going to take a look at. Remind me if I lose it, because it's important to know this, how to monitor and how to prescribe the adequate amount, type and amount of exercise each individual may need, and under what conditions this exercise should be done. And that is the professional aspect of using an, let me say, an athletic trainer on one end, a physical therapist on the other end. And I'm going to explain the difference between all these kind of disciplines if questions come to that. Essentially, I'm going to also go into the fact that strength, which is the other side of this discussion, strength is the amount of activity a muscle can do. Okay, power is the inherent. Okay, that's the scalar quantity, whereas strength is the vector quantity of the power of a muscle. Okay, the torque goes with the angle of movement, the fatally optimal movement, direction of movement. Okay, is based on the line of movement, the torque, and the strength you can get. Okay, so when these are not put together in a proper way, you may move your joints or use weight for exercise and cause injury to your joints or injury to your muscles. But what actually moves the body is muscles. And I do tell people generally, there is no tissue, there is no organ in the body, okay, that does not have muscles controlling its movements. A muscle must contract and relax. I'm going to talk about that. I mentioned earlier on. A muscle must contract and relax for every tissue or organ or system to work. So it's so more important that we should understand that perspective. Everything is about the muscle, and that's the only thing that changes in the body. Your bone do not change during movement. Okay, your blood vessels do not change during movement. Your nerve tissue do not change. Muscles will move to accommodate movement, to accommodate expansion, okay, or collapse of tissues. Muscles will move to open your eyes, to draw in your oxygen, okay, through breathing, to even eat, open your mouth and eat. So, and all muscles have the same characteristics. There is what we call the types of muscles and the strength-length relationship. Like I said, the angular pull and not the other thing. This is what you try to optimize. And that is what makes a difference between, we just came back from France. We just came back from France, including me. I didn't go nowhere, I'm sorry. I was watching on television, those excellent human beings. But they are pushing the limits of what you and I are capable of. And what they do better most of the time, that's why you have a trainer. What they do better is that they teach you the proper running, the proper jumping skills, so that you can maximize the power of your muscles to accomplish better better performance. So we're going to talk about under the FITT principle, which is the intensity, the time and duration. If we're able to get that and not go
so exercise, we got to get to, I think now. So
yes,
that
I understand.
we can give our audience the most
So
benefit.
these are the basics. These are the basics. We're going to get into the exercise right away. And
Yeah,
I'll
because we're timed and
I understand.
Sorry?
So please, if you have any question about any organ system of performance, we'll be able to take it and drill it down a little bit to all. So the first thing I'm going to do now is assessments. If you don't mind, please, I have to spend a minute for that. We don't jump into exercises. So I want to go into exercise. For anybody that is looking for the exercise is performance related, health related. For people who are adults, we are talking about health related exercise, okay, or health related fitness, okay, and we are talking about wellness. So the terminology is wellness, fitness. You cannot be fit for everything 100%. Fitness is achieved for a function, for a set of performance, okay, or from some activities, okay? But wellness is a general term, and it goes with the WHO definition of good health, which is a state of physical and mental well-being, not just the absence of disease conditions. Okay, so before you go into routine scheduled exercise, we normally insist you must have a medical clearance. You must have a prescription from the doctor. You must overlook your organs and system to make sure that the limitations are known. I have never turned back any patient under any condition. Even at the last moment, about terminal patient, and I still insist that movement still has to be done. Exercise must be done at any stage. It gets you better, and it gets the function better. It makes the medication works better. So many times doctors prescribe, and I said, oh, you cannot start exercise yet. Okay, I grew up from the background of University College Hospital in Ibadan and College of Medicine, and of course, and out there, we take our patient even post-op from year one, even from the ICU. Okay, so the medical clearance is important because we want to know ongoing and undercurrent conditions that might limit your performance. Okay, so when we know that you have congestive heart failure as a medical diagnosis, you are being monitored, you are being supervised by a medical practitioner, then we want to have as much what they call it, investigation that will tell us what should be your limitation. So we want to know the risk factors and predisposing factors. So when I'm assessing a patient, these are the first things that we have to document. Okay, we call that the medical screening. You screen for ongoing and undercurrent cardiovascular diseases. You screen for other overriding disease conditions. Then you screen for risk factors and predisposing factors on every single patient. Following that, we have that informed consent have to be signed by the patient, and we have to offer patient education.
Dr. Popoola,
yes,
I'm so sorry to interject. I want to remind you of who our audience are.
Yes,
that they are not all medical practitioners, so the consent and stuff like that, they will not know. I would suggest that we go into the exercises and then leave space for question and answers where you can then fit in the rest of these things.
Okay. All right. The last line there is that you just don't jump into exercise. We have to make sure that we'll make some background preparation to prepare you for the exercise. And the next thing we're going to the necessity of prescription, planning, monitoring, and even the correct dressing for exercise. You might see that I'm in something that looks like an exercise outfit, if I may stand up. That's my exercise outfit, and it's loose enough, okay, at the same time, it's firm enough on my body. So that is, it's not loose in such a way that it's going to get caught on any of the machines, especially moving parts of machines, or get caught in furniture as I'm moving around. So it has to actually be fitted. Okay. It's also good enough, let's say when you're doing aerobic exercises, you have to put a dressing on that actually protects you from losing too much heat, at the same time permitting a layer of air between your skin and your body to reduce the effect of sweat pulling on your body, and that causes heat in some other areas. I'm going to go back to it. So it's loose enough, okay? And this prepares me for cardiovascular exercises, okay? A little bit more than any other thing. And of course, you can see the pants and you can see the footwear too. Allows me to be able to do that, okay? It's flexible enough and it's a non-skid sole, okay? And of course, I didn't strap it down in such a way that I want to have. So I got enough room, another thing, but it's just firm enough. So the correct dressing for exercises or preparation is part of the preparation you come into. All right. So let's start. We introduce the proper physical rehab consultants, and I'm also going to. Okay. That's my exercise mat. Okay. And also, right in the corner here, right where we're going to do most of the exercise, that I have right in front of me a mirror that my patient can actually relate with. I just increase the size of this space to allow me to skip and jump as necessary. So, circuit exercise, I'm going to start from the arm and shoulder. This is musculoskeletal, primarily. I'm going to go to the circuit. Okay. Now, what I'm going to do is I'm pushing this all the way up. Okay. So if I ask you which muscles am I exercising under this condition, let me start by this. I'm sitting. I have a ball between my knees so that there is hip, knee, ankle alignment. That's the first thing. My shoulder aligned, and I'm going to put my head against the board. Okay, why am I doing that? If I keep on pushing, okay, and exerting maximum force or submax force in this position, what's happening? I'll be straining my nerve. So if I happen to have had a pinched nerve or intervertebral disc dysfunction, I'm going to aggravate it, I'm going to worsen it, okay? And also, that will not just be my exercise, that is, I'll be contributing to the disability of the patient, an impairment of the patient, impairment of in the area, and further disability I'm taking up for. So my head has to be against the board so that the movement is isolated to the muscle group I'm working on, and I'm relieving my neck. Usually, I'll put a towel to go into the curvature, that is the concavity of the neck to support it. I have something I'll do that later. Okay, and when I push it up, the whole idea is to get the range of motion. Exercises for every group of muscle talks about outer range, middle range, inner range of motion. Okay, and every movement is supposed to be reciprocal, in which case there is going to be a flexive direction and there's going to be an extension direction. At this point, I'm going to quickly ink it in. Every muscle works as agonist, antagonist, fixator, or synergist. In every single full range of motion, in every single angle of motion, all muscles it to change in how they go into whether they are going to be agonists or antagonists or synergists or fixators. So it's not that cut that these are the agonists. So agonists for shoulder elevation, okay? Okay, the antagonist will be my subscapular and the other group of muscles. I won't go to that detail, but basically, just know that every group of muscles functions in all those four categories of basic muscular activity. The purpose of this is that the joint has to be stabilized, because if the agonist moves further or quicker than the antagonist, then you are likely to have a kind of disruption or dislocation at your muscle level, and it can also cause impingement. So the synergies are muscle groups that at that particular time, with that particular motion, they are guiding the agonist complete the movement, whereas the antagonists are relaxing to let the movement take place. The fixators stabilizes the joint so that it's not displaced. Okay, when we get to the knee area, we'll talk about which is working as agonists, antagonists, and fixators and synergists. But basically, all the group of muscles around the joint will function in all the categories. The big thing that they will bother a part 2, part 3 physical therapy student is to do that muscle analysis. And usually at that time, it was not falling top. You just don't remember that's at work. But these days, we tell you to do it, but we are mindful of what is happening. So when a patient comes in and cannot perform a particular movement, we'll look for ways to make sure the movement is done, okay, by activating the groups of muscles at where we want. People that have frozen shoulder is particularly interesting, and over 75% of adults will have stiffness of the shoulder one way or the other. Passive bursitis is the most common one, and that affects the shoulder. That's the long extension or blood pressure of the shoulder. That's the bicuspidal tendonitis. So usually it forms debris of calcium deposits in the shoulder and causes pain, or sometimes the bursa, the top abdominal bursa, has been ruptured after so many years of the tendon flying over the bursa regularly. So we have this in place, and we can always influence its repair and recovery just using that principle. We still get the movement done. So in some circumstances, the point will tell the patient, work in your middle range. Okay? In which case, you get your middle range, and you're staying there. Usually, it's always pain-free at that time for most people. Then gradually, we can increase, okay, the diametric range of motion into outer or middle range until they can achieve the full range of motion. Of course, this kind of machine, you expect it. It has a button that you can use to regulate the amount of tension in the equipment. This is for shoulder and shoulder girdle exercises. That is the upper arm and shoulder girdle. Okay, we're going to move then to the next one, which is going to work on my elbow. Whatever I missed at the station, I'm going to put it back in the other station. How many repetitions of that movement would want to, and what determines how many repetitions will be done? That depends on the goal of treatment. If the treatment is for endurance, that means you want to do more repetitions. Okay, you are concerned with how many repetitions you are going to do. We'll keep it that we call it 1RL. That is the amount of force that a muscle group can support with one movement. That's 1RL. That is the maximum I can support. So when I want to do endurance exercise on that group of muscles, I keep my exercise at 40% to 60% of the measured 1RM of the patient or the client. Okay, so, and if I want to do strength exercises, I know I'm going to go for about 40 to about 80 or 85%. Okay, of course, athletes that went to the Olympics, they want to go to 105% if they can. So that's the bottom line of all exercises. We set a goal and we start monitoring. How do we monitor? Sometimes we monitor the repetition. Okay, the exercise has to be correctly done, and we guide the patient. We support as much as possible. Okay, and the range of motion we guide it to as much as possible. Are we emphasizing movement in the outer range, in the middle range, or the inner range, depending on the kind of kinetic limitation? Because what we call it pathokinesiology in physical therapy. To determine the pathokinesiology, that is the limitation, the impairment that is causing limitation in a group of muscles, actually, usually at the tendon level, at the ligament level, at the fascial level, and the whole movement, okay, of the muscle. So that is the repetition based on repetition maximum. Another thing we want to do when we want to strengthen muscle, okay, if I'm going to do endurance exercise on a group of muscles, I have two choices. Should I start from the very heavy, that is, if I'm taking about 80% of the 1 RM, okay, and I do about 10 repetitions of that, of course, my patient will have been near agonizing pain. And I say, you know what? We want to improve your endurance, want to improve the strength of endurance, depending on what we want to use. Okay? And I said, oh, do 80%, then, 5 repetitions, we'll do 60% of 1 RM, 10 repetitions, we'll do 40% of the 1 RM, that is in terms of intensity, or in terms of the amount of weight we are loading the patient on. If 1 RM is 10 pounds, and 8 pounds will be like 80% of that, and we use the appropriate weight, and 40 pounds, of course, what do you call it? 40 pounds will be, what am I saying? Will be 40%. Okay, so I'm either building up or building down. What makes me decide whether I'm going to start graduating from 10, 20, 40 to 50% or 70, 75% of what RM, or start from 80 and start scaling down? Depends on the goal for the exercise that the patient has. If the patient is has particular objective based on what we have said, the reason was sent to physical therapy, our assessment, and of course the patient's need will determine whether we are going to use that protocol of either ramping up or reducing. We still have to now say how many times do we repeat that cycle and how many days a week. In the next session, I will mention the days of repetition. Okay, let me see the one of shoulder. Can we come over here? This little guy I'm carrying, don't think it's just so easy. That's a 9-pound medicine ball. And we got in so many categories. Yeah, Fatima could handle it. Okay, there's the shoulder wheel. The shoulder wheel particular allows me to do circumduction. That shoulder circumduction. Okay, and that will be torture for most patients that have rotator cuff disability and dysfunction. That have, like we said, vertebral tendinitis, that have the bursitis of the shoulder, and also that possibly have other limitations, neuromuscular limitations. We're going to talk about that in a minute. So I have up here to increase or reduce the tension in the shoulder wheel. Of course, like I said, it's the same principle. How many repetitions will I use as the lowest and the middle range, or the intensity and the high intensity? Remember, I have determined I'm going to go from this level to that level. And the patient then gets better, the number of times we can do it, and how the patient feels at the end of the exercise will also be things that has a motivation. I'm going to talk about that quickly now.
So, Popoola, I'm sorry, I'm going to have to interject again, and I'm responding to the sentiments that I'm getting. most people don't have this at home. Most are not even registered in a gym. So what we're looking for is exercises that we can do at home to assist us. These equipments are
I promise you, when you see the principles, then we'll apply it to open floor and home activities. I can tell you the truth, it does about that.
We are looking at the time, and it's almost 8. So
it's almost 8.
Yes,
let's go to where Poppy will be rolling on the mat. I love that.
We want home exercises, what we can do that is reproducible. You are fantastic. You are a great educator, and we know that you're so skilled. It's just that we don't have these equipments at home. Thank you so much.
All of us have a space in the home. I choose this narrow hallway and I put the carpet there for a reason. And there's a mirror opposite me there. There's another room here for electrical treatment. So I'm going to shut that room so that we don't get distracted. Can I move this a little bit away too? Yeah, you can show them. There's no secret room. They are all accepting for patient care. Okay. Yeah. Okay. The mirror is a companion in the home when you want to exercise. Exercise is not easily done when there's nothing motivating you. What I was trying to describe out there is the number of times you repeat, the amount of weight or load you put on the machine, or you put on the weights you are using, ankle cup weight or dumbbell or what do you call it, elastic, what do you call it, stretch band. Those are the 3. I'm going to demonstrate with each of them. Stretch band, weight, ankle cup weight, and dumb weight. What I said, dead weights. That's what I call them. So we're going to demonstrate with all of those. But the same principle, whether you're using the machine or whether you are using all these other little things. So number 1, I promised I was going to show you one exercise that does cardiovascular, that does strengthening, that does endurance, and does range of motion. And essentially, it is strengthening cardiovascular, strengthening musculoskeletal. Okay? And that exercise can be done in standing, in sitting, and in laying down. It's the same exercise. So what we call this starting position of exercise. So I'm going to start from standing so that to work your appetite before I go to doing it in sitting and doing it laying down. Okay? Starting position of exercise means what position are you starting from? It's always standing, kneeling, sitting, laying down, supine, prone, and on sideline. So if I'm in this position, I want to do the exercise that takes the entire body. If you look at what I'm going to do, the entire body that I need essentially will be fascinated by my limbs. Okay? And it affects my torso. So the first thing is my hand is coming above my head and I'm putting it together. Okay? And I'm rotating it out and bringing it down. I'm turning it up, palm up. Okay? And rotating it down, palm down. The good thing is this to remember. Every movement the upper extremity does, the hand does upwards, is that you want to feed. Okay? You want to eat, your palm turns up. You want to fix your glasses, your palm turns up. You want to comb your hair, your palm turns up. I want to go down, the palm goes down. Any shoulder problem will use to that. Okay? So let me start. I supinate, what we call the anatomical position generally. Okay? And I bring it up, palm to palm. Okay? And I turn it over. Okay? So I supinate to bring it up, pronate to bring it down. Any arm problem, and when I'm going forward in the same direction. Okay? Now, wherever the body goes, wherever the head goes, the body goes. there's no movement to do that your head and neck don't turn towards the segment that is moving. Okay? And there are no movement to do that your torso do not rotate. Okay? Okay? In the direction away from the movement. Okay? And your girdles do not shift in terms of shift to one side or to the other, lateral shift happens in the girdle. Every movement will do that. Okay, so let me show you the exercise. When I go, I'm go on my tippy toe, and simultaneously my hand comes there. Okay, you can see my shoulder girdle is involved. Okay, my arms are involved. Okay, and my arms are also involved. And I turn it down, all the joints of the upper extremity are involved. Okay, and it's like I'm lifting up to my tippy toe. Okay, how many of these will I do? It depends on what I'm functioning with. Am I going to carry dumbbells like weights? Okay, I could use the ball anyway, but we'll do it that next moment. Okay, if I'm going to turn my hand up and carry weights in my hand, okay, I could do that. But I tell you the truth, for 50 years and above, I just said, your body weight you are displacing against gravity is enough load for your system to cope with. So usually you will do about 50, about 10 of these, okay? And you can take a rest, and I'll do it forward. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Can I do it backward? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay. Now I'm breathing heavily already. Not because I'm not fit, it's just because the exercise will task my cardiovascular system. Okay, my heart rate has improved, has increased, and you can always monitor. So before exercise, we'll take all these baseline measurements. Take your heart rate. Okay, if you have a blood pressure cuff, a machine in the house, take your blood pressure. Okay, after each exercise bout, take a rest. How do you rest? 1-to-1, 5 minutes of exercise, 5 minutes of rest. That's 1-to-1. 10 minutes of exercise, 5 minutes rest. That's 1-to-2. Okay? So depending on your goal of exercise and your fitness level, you have walk rest intervals that you have to put in. So when you start, usually I normally suggest, why don't you start from 1-to-1 or even 1-to-2? That is 5 minutes exercise, 10 minutes rest. Because the number of times you repeat adds up. So don't kill yourself putting too many in at a time and not getting too weak to continue and not getting too sore to do it the next day. Okay? So repeating repetition is the way to build both strength and endurance. Okay? Of course, because cardiovascular strength and endurance. Repetition. Okay. So we're going to go through that again. If anybody wants to do it with me, I'm going to do it 10 more times. I believe I have my 1-to-1 exercise and rest. You might see that my voice has stabilized. That's another clue. Any exercise you do and you cannot maintain conversation, that means you are over-exerting your cardiovascular system. And that's some of the reasons why we tell people you can play music and sing to it, or you can be talking to somebody. If I'm doing it, can you talk and make it? Then that means I am overloading my cardiovascular system. Apparently, that is going to be about 80% of my VO2 max. Okay? We're going to talk about it if you want to ask questions about it later. But we want to keep aerobic exercise to 40 to 60% of your VO2 max. And the way to know it is that you can maintain conversation while you are doing your exercise. Okay? But as you go further, you might see that you will do much more before you get to that VO2 level where you cannot be able to maintain a conversation where you're talking. I'm not saying that lengthy conversation like I'm talking, but at least basic conversation that, can you get me a glass of water? Please make sure something is going on. Can you check the stove and make sure, see, that kind of short conversation. If you cannot do that, then you are doing 80 to 85% of your mass, and that is too much for aerobic conditioning. This same exercise will be done in sitting, but before I go there, let me also go to the torso. Okay? This is excellent for shoulder girdle. Okay? The circumduction in your shoulder. Okay? And that one too, we can talk about the inner range, and you can talk in wider expanse of the range of motion, to divide into inner, outer, and middle range of motion. You should be conscious of that. When there's your limitation, that is your pain, okay? When is it occurring? Is it when you go further back or when you come further forward? We can settle on the impairment that is associated with that. Rotator cuff dysfunction or just imbalance of the muscles. That is one group of muscles being excessively stronger than the other. If we have 1 minute, we'll talk about it: spastic muscles, flaccid muscles, normal tone, and different abnormalities of tone of muscles. All right, so we got that. That is always going in conjunction with this. Okay, by the time I've watched through that place, the next one I normally ask people to do, okay, is 1 foot forward, 1 foot backward, just to make sure you are stable, you have a stable base. The wider your base, if it's so wide, then it's not physiologically useful. You want to keep it at the width, okay? Your feet should be apart like the width of your pelvis, okay? So mine is always there reflexing, and I can now do, so if I step 1 step forward, that step is a step with the left leg and a step with the right leg gives me a stride, okay? So let's just keep some of, I will intermingle those terminologies as we go on. So a step forward in this position, and the opposite end, if I turn it up this way, that supination again, palm facing up, I can go further up. With any shoulder problem, we'll be able to go a bit further. If we cannot go that further, what do? And I'll tell you that something is limiting it, like we said, all those impairments. And you can use the other end to assist it, to push it a little bit. Get what we call the end feel. End feel is what makes your joint, that movement, to be restricted. Is it pain? Okay. Is it just that it cannot go because there's approximation, that is, bone is touching bone or bone is touching flesh, in which case the joint cannot move anymore. Okay, so we have the end feel. You must be able to determine the end feel of any movement. Then I'll turn it down and sweep it back. Okay, and that is essentially very good for your vertebrae tendonitis. Okay, the pain that drops in your tip of the shoulder. This is the exercise for it. Turn it up and bring it up. If it's giving you a little bit more problem, then that means the tendon is not going smoothly in the groove. It's either sliding around or the tendon has been ripped so much that it cannot sustain. So sometimes you can feel it yourself. Just put your hand against that painful spot and do that movement to let it go. In which case you are reinforcing that tendon and you are keeping the joint supported. Okay, I can do it from the side as well and get it across. So that is it for shoulder girdle. I will go to wrist and other thing in a minute. Okay, so now to do the exercise in sitting position, I'm going to do it on the floor, then I'm going to do it on the chair in 1 minute. On the floor, I am sitting in, this is long sitting. Okay, now to do this exercise, I can put weight. If my left leg is weaker than my right, okay, a chain is as weak as its weakest link. If you want to get a more balanced movement, the leg that is weaker, that's the one you're going to put weight on. I find people doing the opposite every time. Okay, if you are supporting somebody that has weakness on any side of the body, that's the sign you should be when you are the spouse, the brother, the sister, or the caregiver. Okay, because reflexly your brain adjusts to try to avoid putting weight on the weaker side, so that the opposite leg now will be overworking while the affected leg is not getting any stimulus to get better. And that will affect what we have said, muscle pump and blood flow, and the disability and dysfunction and the degeneration or the deterioration of the impairments will continue to sustain. It's not going to get better, and the other leg will be affected. So instead of that, I'm going to also mention right away, when I treat my stroke patient, I decide on what to do. I can put the weight 80% of time on the weak leg, okay, or on the other arm, stronger arm, contralateral arm, because in movement, right angle with left leg, left angle with right leg. So when I'm now doing this movement, I call it wiggle and wriggle, wiggle and wiggle, wriggle, wiggle, wriggle, wiggle and wriggle. When I got to this country, I didn't think anybody was doing it. And I was always trying to explain it to my colleagues and to my clients. And it came to me, just said them, wiggle, wriggle, wiggle, wriggle forwards, wiggle, wriggle, wiggle backwards. Now there's a difference now. I'm doing it freely. Okay, I can be reading my book. It's more noble. I can, okay, I don't want it to be testy. Okay, I can be doing so many other things. But when I'm doing this, okay, wiggle, wriggle, wiggle, wriggle is actually about 40 to 60% of normal walking. So if you're having balance problem, you're not shifting weight to your right leg or right side or left side, okay, just put a weight on the weaker side and make sure you can pick your pelvis up. Okay, I'm lifting it clear up, and you can look at my foot. One foot is going past the other. Keep your attention that your foot is actually going far and you're picking up your hip. So when you modify that to equate it as best as possible, making sure that, excuse me, making sure that you're keeping count of how many times you are going forward and backward, you will see that you get up and you walk a lot better, even after one bout of exercise or repeating a number of times. Why do we repeat it? We'll repeat it for how many, how far, okay? What makes us know when to stop, or when we're doing too much, we can't sustain a conversation. We start having a cough like I had, okay? We start panting and looking for breath. You are not doing yourself any good if you are exercising to that point and think you are conditioning your aerobic system. You are overbeating it, and you can go into crisis. If we have some time, we'll tell also deleterious effect of exercises which can occur under certain conditions. So this is the classical. Okay, if I'm doing this, it's like I'm walking. Okay, normal walking. Every single patient of mine goes through this because it has significant cardiovascular effect and also strengthening effect. You might see that my girdle and my lower trunk is actually lifting my body weight. So it's considerable exercise. When I put my hand on the lap, that's a different leverage from when I put it on my waist, and different from when I'm using it to also pump my body, which is the easiest. And when I can't do it that way, I still put my hand down, because the important thing is to displace your body weight from the left side to the right side. When you and I are working, we're actually shifting our weight from one leg to the other. Funny enough, when you have disability or injury, you want to avoid putting your weight on the weaker leg or an injured leg. Sometimes we want to even move the two legs at the same time. Or sometimes we want to keep the two legs on the floor just because of, and that determines, I can tell you, all the kind of gait abnormalities and what we can do to impact what they are doing. And what we are saying, the more you do it normally, the more your brain recalibrates your body. There is no condition, neurologic, orthopedic, okay, metabolic that do not respond to the brain, allowing the body to make movement. The brain wants to withhold treatment, movement of any segment that is ailing. It's a natural thing. And we try to deceive the brain, okay, by finding ways to make sure movements are done as closely as possible to the normal pattern. Okay, so let's quickly move to another exercise, wiggle and wriggle. Number 1, number 2 of essential exercises that you can do. You can see that all these exercises I've done so far, I'm not putting any strain on my knee. Even if your arthritis is so very bad, you will do it successfully, okay? You will gain range of motion, and as you move your joints forward and back, okay, your muscles is getting more pliable. The joint is getting more pliable, and the synovial membrane is producing the synovial fluid that lubricates your joint. So any kind of stiffness will get better when you do range of motion exercises without crunching weight against the already over dry or broken cartilage. Any kind of joint, I will move it by the grace of God, okay? Because I know movement will restore it as much as possible. And if the worst comes to the worst, I'll ask the special surgeon, can you put an injection and put some of this medication in that lubricates the joint externally until we can let your synovial membrane produce the synovial fluid that lubricates the joint. But moving the joint to, so if you can't do it to the entire range of motion, usually when it's orthopedic, it will allow you to do it in the middle range, okay? Or you can do it in the outer range or in the inner range. Whichever you are doing, you can start building on it in percentages of how many repetitions and against how much resistance or force. So we're in this position. Let's go to the torso, where the bulk of back pain is, okay? And the back pain may radiate to your leg as sciatica. The back pain may radiate to your leg also through piriformis syndrome, and also from poinsettia, where you have the trochanteric arthritis. Okay, let me just put it that way. I'll get the proper word in a minute. Okay, so these are the 3 areas where you have it in your pelvic area. And secondly, you can also have in your sacrococcygeal area, because the coccyx in most people is poorly vascularized, and it's still a living tissue. Okay, so usually there's a lot of pain there. Prolonged sitting in the office, prolonged sitting in the home makes your back slump, and you lose the physiological curvature, that's the lumbar curvature that allows the spine to actually have its resilience. So what I'm talking when I'm addressing back pain is that I want to improve the resilience of your back. Okay, I want to improve the dexterity of your muscles in the back. Okay, now what will affect your back? We just said it. Degenerative joint diseases, rupture of the disc, or of course, spondylosis of the spine. So let me go into this position, hook line position. A towel roll in the neck is always good. Everywhere where there's a curvature in your body, the neck, the lumbar area, it's always good to put a towel roll there. I wish my third person is around to give me the towel roll.
I can actually hand this to you right now.
Yeah, they go bring the towel roll. Always put a towel roll. Usually there are, she's been gone. Usually there are rolls that you can buy off the shelf, but the towel roll is the most significant. Can I have this? Thank you. Yeah, no, drop it there. Drop it there. I'll take care of it. Yeah. Okay.
The screen is blank. We can see.
That's the towel now, not my towel. Okay, it's the towel roll. When I roll it and I put it in under my neck, under the curvature, the cervical curvature. Okay, okay. I can put it in there. It supports the curvature, and that's your most important treatment for any neck ailment. Okay, and keep it in the middle. Okay, if you are going to use a pillow, you use a string right through the middle of the pillow and put your head inside it. Okay, your shoulder will be supported. The roll is good because you can always roll it more or less to fit your curvature. Okay, similarly, I can do a similar thing in my lumbar area, in which case I have the roll. I'm going to roll it this way. Okay, and I have it right under my lumbar area. So if it's too thick, I release the roll a little bit. And if it's too thin, I'll get it back. From time to time, from day to day, you may alter the amount of roll. If I'm going to be in long sitting for a long time, similarly, I have the roll and I can put it right behind my knee. All the area of concavities are the area where the body absorbs shock, okay, and there is the strain on the joints in those areas. So they themselves are therapeutic, okay? And the last place you put it is going to be behind your ankle to support your tendon Achilles. If you put it in those places and you haven't been sleeping well, you will pretty sleep, okay? Because that means the muscles in those areas finally gets to relax. And when they relax, they're going to serve you better, okay? So that is it. And if I'm doing this exercise again, as usual, I'm going to put a ball between my knees to make sure that my hip, knee, ankle alignment. Sometimes I put the ball between the knees, between the thighs, and also between my feet to make sure that there's alignment there. So in this position, when I put my hand by the side, give me a different leverage. When I put it behind my head, give a different leverage and increases the area of the torso that this exercise will impact. The most important exercise for the lower back is called pelvic tilt or anterior posterior pelvic tilt. Look at what I'm doing. I'm going to crunch on that tower and my pelvis will tilt. This is my pelvis. Okay? Can you see? It rolls back. That's tilting. Okay? And you repeat a number of times, just like we said, based on the exercise principles. Pelvic tilt repeated a number of times is going to improve the dexterity. If it's not the solution to your back pain, it is not going to contribute anything worse. It's going to make movement a lot better and going to relieve the tension there. The worst thing in your back is spondylolisthesis. And that means your back has your backbone, that is the vertebra, one sets upon the other with a disc interspacing it. So when the lower vertebra juts out further forwards or backwards, that is spondylolisthesis, either retrolistesis or anterolistesis. Retrolistesis means it slides back. It is dangerous. So when you are hooked down, sometimes that is what has happened. When you are hooked down, sometimes because you have disc, your disc has ruptured, the vertebral disc, and there's impingement on the nerve roots or the nerve itself that becomes sciatica. So this definitely will always support it. So you will not do anything except if you have place of backrest for a prolonged period of time, have a lumbar roll there. It will work every time because it's going to stabilize and support that curvature. When it supports it, then the muscles can go to rest. The reason is most of the problem we have there is fatigue of the muscle. When the muscle, like we're saying, muscles contract and relax. That is their physiology. So when they have to hold rigidly, what happens? Can you do that for me in your respective arms? Clench your fist. Clench it so strongly and count. The longer you hold the clench, okay, the weaker your grip goes, okay, and the more the pain starts. But if you contract and relax, you can do that a lot more. That's the effect. Because each contraction is using energy and relaxation is releasing. So rest, walk, walk, rest, walk, rest. Agonist contract, antagonist relax, and the opposite movement allows the opposite movement. We call it reciprocal contractility. That is reciprocating movement. Any movement side to side, okay, up and down, you're changing which muscles are agonists, which one are antagonists, which one are synergists, which one are fixators. Like I said, all muscles work in all those. So when you have unstable joints, all I'm looking for at which area of movement, which segment of the movement cycle, okay, do you have that instability? And which area can I support? If I have to use a brace to support it, or tape it, or strap it, then we have to do it. Okay, I was doing it because I forgot. I was enjoying myself, actually. Okay, this goes a long way because it's working on your lower abdomen and your pelvis. Okay, always so easy. The number of repetitions can vary on what you're doing. If I have a weight between my legs, or if I have a straight band, I can hold the straight band again. Can you have a straight band for me there? Yeah. Okay. All right. If I have a straight band, I can put the straight band against the weight area and hold it. So when I'm pulling that way, I'm pulling against the side of the straight band. Okay. And when I'm coming, of course, the straight band is assisting the movement. Okay. If I want to do it reciprocally, then I can put it on the other side too. This is for the purpose of doing that though. Put a straight band, wrap it around, hold it in one end, okay, as far as it can go. The color of the straight band will tell you the strength of it. Usually, pink and red are the weakest, blue and black are the toughest. Okay, I don't ask me what I stick with. I'm always on pink and red zone. Don't mind me. Okay, so that goes. So that is pelvic tilt, the most important exercise routinely done. It also improves the tone of your muscle. It allows the rectus abdominis to do what we call braiding. Okay? At the same time, it allows the back muscles, okay? The back extensors to be stretched and relaxed. Very, very essential to work upon it. The rotation, of course, is for your rotators of the pelvis and of the lower torso. These themselves. If I have this straightened out, I can similarly do it for the upper edge of the upper half of my body. I can reach further as far as I can. So if I'm doing it a little bit across my lower half, there's a different leverage than if I do it along my shoulder and if I do it on the opposite side. It depends on the specificity of the exercise. You can target the area of weakness. As I said, a chain is as weak as its weakest link. Okay, excellent position to do so many exercises. Hook line position, you will work on your torso successfully. Remember the neck row, the lumbar row, and the row behind your knees, the ball between your knees to keep your hip, knee, ankle alignment are the essential aspect. Any movement you deviate from normal will not have an efficient movement. You are going to use much more energy and you are going to get worse results, and perhaps you are going to strain your joints or strain the muscles. Let's make a difference. You strain muscles, you sprain tendons. Okay? Terminology matters from time to time. All right. If you are getting up, anybody that is older than me, okay, you must roll on both sides. It's always easy. Call up, okay, and then get up. Okay? Except you are fit like some people that I know, then you can try to do get up that way and get up that way. Can I do it?
Yes, you did it.
Okay. You did it. I have a question for you. It's a very important one. Yep. A young lady who had a TBI, traumatic brain injury,
yep.
and that affected the left side.
Okay.
Causing her to have difficulty walking. Now, this TBI occurred about 3 years ago. She has difficulty walking. this has affected her left side. Are these exercises good for her, or would you suggest something, exercises that would help for her to be able to start walking like she should?
Yeah, thank you so very much. That is classical interventional physical therapy. That is different from conditioning exercise. All this exercise we do, every single patient benefits from it. Because bottom line, you still have to get a cardiovascular system, you still got to get a neuromusculoskeletal system to be in proper tone before any movement can be done. Whether you, okay, the patient you're talking possibly was having an hemiplegic gait, which is, I wouldn't say she was pretty lucky with the tibia. Tibia can be a lot worse. And we have so many gait abnormalities. So if it affects one side, which is hemiplegia, or hemiparesis, or hemispasticity, okay, we're dealing with the difference of tone. Usually there's going to be spasticity because the control centers in the brain for movement. That's a whole lot of little science that we attend to. When I see a patient walks, I can almost tell you which part of the brain is affected. Not just what side of the brain, but which tissue in the brain is affected. Okay, so usually when it comes to this, what do you call it, TBI, traumatic brain injury, it could affect any area because there must have been a lot of bleeding to so many areas. But if it ended up after the whole thing have relieved, we call it umbra. Umbra is where the lesion is. Penumbra is the surrounding areas that may improve or that may deteriorate. So your patient is possibly, if it's affected the left side, if the patient is walking with a spastic gait, you can show that, okay? Going with a spastic gait, unable to move the spastic gait, that's the easiest thing we can get from TBI. TBI can be what? TBI can let you have a diplegic gait.
Okay, so what exercises, you just said that all the exercises you did.
All the things I just said is basic for exercise. One way or the other, I will get my patient to do these exercises as best as he or she can. Okay, now when it now comes to hemiplegia, which possibly you have described for this patient, the amount of abnormality of tone will tell us what is going to impair the movement and the kind of tonic abnormality. Is this flaccid? Is this spastic? Okay, and is this attetoid, in which case it's just varying. Okay, will determine what we are going to use to stabilize the joint. Movement must be done. Movement must be done as closely to normal as possible. Okay, how do we intervene? We intervene to let the patient be able to do what we're just describing, to be able to walk, to be able to move segments in as a normal way as possible. That is the professionalism in physical therapy. Okay,
so let me interject one more time. All the exercises you just showed us is okay for this patient to do. For you to recommend further, the patient needs to be evaluated.
No, I'm going to give some tips to the patient.
So please give us the tips. I want other people to be able to answer the question.
So this patient that has hemispasticity, most upper motor neuron lesions will come with different levels of spasticity. Okay? Now, spasticity prevents you to be able to control the muscle. But the secret of it is that when it affects one side, your torso from your neck to your waist belongs to both sides of the brain. Okay? And that's the secret. Okay? So the first thing is to ask the patient, okay, to turn and look at that segment. Okay? It opens up pathways in the brain. Okay? Now for the patient to put weight on the leg is the worst problem. The patient will not want to move weight. There won't be lateral shift over to the leg because the brain will not want to allow it. Okay? And the patient will lose balance. And the more it loses balance, the brain becomes more tight. When I started, me that want to help the patient, I will be on the side that is having the abnormality. Me that have the patient, I know what I call synergy, abnormal synergy, normal synergy. When the hand goes in there this way and goes out there, if you pull the thumb out, the patient will relax a little bit more, and this will relax a little bit more. So I'm going to prop the thumb out, stand on the side of the patient, okay, and shift the body weight for the patient by putting a belt around the patient, okay. I will be shifting the waist for him from one side to the other. Okay, if the patient comes with the head that is cut to one side, I'll put a soft cervical collar under the neck to keep it in midline position as much as possible. Okay, if the patient still refuses to shift the body weight to the affected side, sometimes it's tough. I'm going to put a very heavy weight on the contralateral leg. And people wonder why you want to. I said, when I put big weight on it and the brain realizes to leave that weight, he has to shift because you can't load it down and move it at the same time. The brain will release it, the patient will be able to walk a little bit better. Okay? Now, they have to use other things to make sure that the foot comes from the abnormal position where it is, which is spastic in the drop foot position. Yeah, I may have to do that. I may have to use a brace on the knee. Okay? But before I consider that, all I have to do is break the spasticity and break the synergy pattern. That's why it becomes, but bottom line, I want normal movement as normal as possible. The closer to normal, then you are rehabilitating the patient. If you are doing anything otherwise, you will be reinforcing the abnormality and the patient will be stuck. And I say, the preponderance of patients, they are not intervening. They are actually just managing them. Okay? We'll give them workout, we'll give them kids, and they are dragging themselves all over. And so the patient will not walk because they are afraid of walking. Okay? Because the brain tells them you cannot walk. And well, you can only walk when you shift weight from one side to the other. Just to get the patient to shift weight, yeah, it could be Achillean, I can tell you the truth. But like I said, you want to break the spastic pattern, you want to break the synergy, you want to read the spasticity. Okay, then you want to assist the patient to do the lateral weight change. If your patient came to me with a caregiver, I'll tell the caregiver, stand on your left side, stand a few feet away from us, okay, so that the patient can keep attention towards the affected side. That is when you have hemispasticity or hemiparesis. Anything hemi, the weak side, you have to facilitate it. Okay, we call it facilitation. And there are so many techniques to facilitate depending on the condition and the stage of the condition.
Thank you so much. Appreciate that. Mr. Imodi, kindly unmute and ask your question. Thank you.
Thank you so much, Doc. Thank you, Dr. Popoola, for the stretches specifically, really. So my first question is,
camera person, can you please lower it so that we can see? Thank you. That's a better posture. Thank you so much. Yeah, go ahead. Sorry. Yeah, thank you.
The first part of my question is regarding stretches.
Yes,
Now,
sir.
stretches versus cardiovascular or body strengthening. Could you, do you really need the cardiovascular if you stretch all the stretches that you've just done, but for upper body, lower body, perfect. If you stay on just stretches alone, probably about 20 minutes a day, will that suffice as opposed to, adding on the cardiovascular and the strengthening and using the equipment? That's the first part. The second part is you talked about constant movement. So now, when you stretching, do you really need to break that constant movement? Because I'm assuming it takes away from your constant movement, from one stretch to the other, and you break into rest. Will that really interfere with the performance, the overall performance? And then finally, there's this popular saying about no pain, no gain. In terms of exercising. Is that really something to look forward to, or it's just it's something that is not really practical, for the simple fact that I've always believed that when you stretching or exercising and you get to the point of pain, you stop right there, retrieve to where you were before you got to that point of pain.
Yeah. Okay, thank you so very much. You put so many into perspective. Is there any colleague physical therapist in the room?
I'm not.
Okay. Now, stretching exercises is done as a way of preparing the joints for movement. Okay. There is normal muscle length, and there is shorter and longer muscle length.
Mhm.
Okay, the optimal muscle length in a physiological position, put in a proper position. So anytime there is a limitation in range of motion, movement will be impacted, joint angle will vary, and the functioning of those muscles will be affected. So before we do any exercise, we want to stretch to be able to accommodate, for the muscles to show accommodation and the joint to show accommodation. That means to accept the extra load we are putting on them in terms of muscles, length, tension, relationship. That's how we define it. Okay? A muscle contracts stronger when it's stretched. Okay? If it's not, but if it's overstretched, then you are going to damage the joint, because the ligaments that maintain the joint in its physiological physiological relationship, okay, and structure. It's not structural relationship, and the tendons that maintain the physiologic movement, that is the pattern of movement, they work at best at particular muscle length tendon relationship. You must say length, okay, strength relationship. Strength is if I have my hands stretched out, I can pick a heavy weight from this position a little bit better than if you give me the heavy weight from a position and I'm working against gravity. If I'm working in a gravity eliminated position, okay, when the muscle is shorter, then I cannot get as much contraction. Remember, we are talking about muscles involving several fibers put together into different compartments. And when you are making any movement, we call it recruitment. Recruitment means the brain will not let you use the same amount of muscle contraction, okay, when you are picking a pencil and when you are picking up a box, okay? So we have what we call muscular recruitment. But when you want to exercise, general exercise conditioning, we need you to stretch as much as so that you can accommodate the extra load. Now, if you have limitation in the joint range of motion, then we have to stretch because that's an impairment now. Okay? There's an impairment that can be at the level of the muscle. Maybe you saw the muscle before and there's scar tissue already embedded in the muscle tissue. Okay? It needs to be stretched for the arm to stretch completely. Okay? But when it's even stretching completely, we still have the tendon, okay, which is the insertion of the muscle, and the tendon is what carries the strength of the muscle, the power of the muscle, across to the bone to leave the adjacent segments. Okay, so the length tension relationship. So to do any exercise, stretching exercises becomes very essential, okay, so that we can accommodate the movement you want to make. It is essential, it's part of warm-up. Stretching has to, sorry, I didn't mention warm-up, I could have gone into it. Yeah, that's part of the warm-up. Warm-up essentially is stretching exercises, okay, and also some cardiovascular exercises so that there is circulation to for the imminent use of energy that is going to take place during your performance of activity. So that is the issue about stretching. But if you are stretching because there's a limitation in range of motion, of course, we are going to address that and the way to do it. Now, I mentioned end field of motion. If I have a stiff elbow because I had an injury here, okay, in the elbow, and the elbow is stiff in this position. Of course, my bicep muscle is already in a state of contraction. Okay? Like I said, when the muscle is restricted from going through the reciprocal contract, relax, contract, relax, what happens is that the muscle is actually getting weaker, it's not getting stronger. And the longer you restrain the muscle from going through its full range of motion, what happens is that the muscular tissue begins to lose its flexibility, its elasticity, and it starts becoming to be fibrous. And that's what we get in the hamstring muscle, the back of the thigh. And they call that muscle hamstring because it hamstrung it holds you back. And that's the biggest muscle we'd like to strengthen in the body. Okay? And that what happens is that during normal physiology, the hamstring crosses 3 joints. Okay? And we don't use, if I'm working, I'm only using the hamstrings in the distal area. The entire length of the hamstring from the mid-thigh up to the pelvis, okay, that is up to the trochanter, I'm not using it. Talk about the extent of it, which is contributing to hip extension. Okay, that's no use. So usually that's why anytime patient is in bed rest for a long time, or you've been sitting, you've been very sedentary, you are going to have tight hamstrings, and we have to stretch it. It's just because you are not covering the physiologic length of the muscle. Okay? Okay, we are only using, and usually most of us that are adults, I classify myself as one, all we do is walk this way. Look at the hamstrings. The hamstring gets this up to this level, okay, all the way to the hip. I can reach it, okay, but most people cannot. But I'm still using only about 3/5 of the hamstrings, even doing this, okay? Talk less than when I'm just walking, which is just from ear to ear, which I'm using only about 15 to 20% of the hamstring. And most of us for several years, okay, will not use the other aspect of the hamstring. What happens? Okay, it begins to shorten, retract itself because it's not going through. So you have to go through hip extension exercises for the remaining, in which case I bend my knee and I stretch it. Okay, that way I'm getting the entire hamstrings to work. And without one of the most important things, your stabilization of your pelvis depends on the strong gluteus and your hamstring muscle.
Okay.
And so
Thank
when
you
don't
so
do
much.
that,
1 minute. Is it answering your question, Mr. Imodi?
Yeah, I think you are. Just to narrow it down, that's basically you don't really need the cardiovascular. Just stretches alone should be able to, suffice, especially for those in the older age group, like the point of the program tonight. But
okay, let me quickly ask you this.
So
When you stretch, do you feel yourself increasing your breathing rate? Do you feel yourself hyperventilating? That's the cardiovascular impact on it.
No, I don't. But you brought up the point of
no, you will. You will.
Well,
There's no way you will stretch that because it's going to use muscles, it's going to use blood to have the movement happen.
Mr. Imodi, I think
stretching exercises is important because that's the act that said it's preparatory, it's warm up, because it induces cardiovascular adaptation.
okay, so
alongside
Mr. Imodi, I think what Dr. Popoola is saying is that if you're doing the stretches correctly, you would have increased heart rate and blood pressure, and that you feel that you would feel that. That's what is
certainly, and I agree with that. It's just that the warm-up session that the doctor just mentioned also counts, because you do have to do the warm-ups before the stretches. Yeah. So I think you've answered my question now.
That was actually going to be my question. But I want to, Dr. Popoola, sorry. Because, I think, Dr. Imodi, Mr. Imodi, are you satisfied with?
Yeah, yes, I am. Thank you.
Fantastic. I'd like to go to the other questions. Again, I'm looking at time. It's almost 9 o'clock. And if you please give us 2-minute answers to this. How often, or 1 second for this one, how often should these exercises be done? the exercises you showed us?
Number one, we said there is a purpose to any exercise you do. Basic conditioning, you want to at least sweat, moderate sweat, at least for about 20 to 30 minutes.
So she said, how often?
No, I'm coming.
Okay.
So that is the most important thing. We just talk about stretching exercises, and we often talk about training exercise and all the other things. It's aimed at the purpose. So what we say is that I tell people when you are doing endurance, you are doing endurance and conditioning, your most important thing is repetition. Okay? And doing the exercises for just 5 minutes, okay? And repeat the exercises like every 2 hours will be great for anybody, especially if you are completely sedentary. I tell people in the office between the hours of 8 to 3 or to walk. Repeat as anytime you remember me, just do the. It will keep your cardiovascular, it will keep your strength as much as possible. Okay, and you can do it sitting on your chair. What I did on the floor, you can do it also very, very close to what I did. You don't even have to do standing. Okay, so how often depends on your birthday. 100% because of insurance reimbursement is 3 times a week. Leads to 1 hour of exercise. We don't carry the same body, we don't carry the same needs. Okay, anytime you feel short of energy, do some exercise.
So
Anytime
three times a week. Auntie Ajua, 3 times.
Does that answer it?
Auntie Ajua, 3 times a week is the answer.
Auntie Ajua, go to gym 3 times a week like we've been going. But do home exercises at least.
Thank you.
You are
10 minutes.
You are breaking up. But the next question, if we're able to handle it, because you are breaking up, you're going in and out, is what type of exercises is good for brachial plexus injury with unilateral weakness? So I'm going to speak English there. What type of exercises is good for brachial plexus injury with one-sided weakness?
Brachial plexus injury.
2 minutes, please.
Okay, the brachial plexus is the injury to nerve roots in your neck, cervical root injury. And depending on the level that you have the impairment could be any of the one we've said. It could be bony, it could be, and it could be spondylolisthesis have been tied up. So if you have brachial plexus, the first thing is that the impairment that led to it must be considered. To do any exercise in your acute or subacute state, please put a soft cervical collar on. Okay? Okay. Now the exercise you want to do in that area is neck and shoulder exercise. The limit of tolerance. That's the end field. Okay? Remember, the cervical is so important to the entire body because it connects the head to the body and the spinal column passes through there. The brain is interested, is like the turnpike and parkway of the body. Anything that affects it, the body goes, the neck goes to spasm. Okay, and the spasm can go well beyond the. Okay, so if your movement, another thing is aggravating it, there'll be more and more spasm. Okay, but the first thing is that when you have brachial plexus injury, we must find out what is the underlying cause of brachial plexus dysfunction. But if it's something that your spine is not stable and you are not having more and more expulsion of the nuclear corpuscles from degenerative, what do you call it, from disc herniation, or you are not having the spondylolisthesis, that is the one vertebra is moving forward, instability. So if those ones are there, then that's a particular different scenario entirely. I won't jump on the neck Okay, but normally I put traction on, and sometimes I use just cervical collar, and you are free to do some of the exercises. So let's start the exercise for brachial plexus injury, neck and shoulder exercises. Okay, number one, can I take a minute on that?
Okay, please.
Okay. Like I said, you have to have the cervical roll under your cervical curvature. Even if you're standing against the wall, like I'm standing against the wall, excuse me, so that we don't get distracted. If I'm standing against the wall, okay, and the support I have given myself here will stabilize my neck, okay? Even if there is disc adhesion, if it's not adheting at that point, okay, I want to keep it steady. My arm support is again on my shoulder. Of the shoulder girdle also goes into the neck, okay? And I'll start working on them first, okay, to release them. Now look at this. When I pull my shoulder, if I cannot bend my neck, that exacerbating the pain. If I pull my shoulder and I bring my neck down, it will allow me to do it. And I can then drop this, okay, and pick it up, okay? Other times, I drop my neck and I now pull my shoulder to free the movement to start with, okay? And I can do it, anytime you do it to the affected side, you have to do it to the contralateral side. And it's always better to start from the unaffected side. Unilateral means it's to one side of the body, okay? And if there's a disc herniation, we want to there are movements you can do that will get the disc back a little bit. And little by little, if you come regularly for treatment and you do your home exercise program properly, you can actually have the disc material to go back inside if the tear is not too much. If the tear is too much, then we're at a risk of that, and there can be further damage. But the first thing is the girdle is this. When I move my neck to this side, the tone is on the opposite side to stabilize the neck, okay? So movement to the right means that there will be a stretch here, and there's going to be a kind of eccentric contraction of the muscles of this on this side, okay? If I go to this side, there's a tight contraction. So I'm interplaying between what the muscles are doing as restricting the movement, permitting the movement to an extent. Essentially, you want to start freeing it by shoulder movement, okay? And that's number one. Number two is the neck is going to move in all motion of direction. The next one I free is to try and do protraction and retraction, okay? Okay, in the sagittal pain, that we call it, that is in the forward and backward, the sagittal pain goes right through the body like that, okay? So it's protract and relax. And I can isolate it to the upper cervical area, middle cervical area, lower cervical area. Usually it will allow you to do that before you now try to now say, can I now do the diagonal movement? The diagonal movement means your chin is trying to come to this shoulder and your face is going to go to the opposite side. And that is what you use when you walk. It's a diagonal pattern, okay? Diagonal pattern. So those are the three basic things. And when you do, repeat it 2 to 4 times on the affected side, repeat it at the rate of 1 to 2 ratio. You want to do it on the opposite side as well. So start by trying to free, because the shoulder muscles, you can do all of them, okay? I know I tell you, you're actually tricking the brain. And if worse comes to the worst, support it, okay? And do what I call resistance exercise. If you cannot move the joint because of pain, okay, because pain makes the pathology, the pathokinesiology, okay, worse off, then put a resistance, or let somebody resist it, and try and push against it, and I will call it contract, relax, contract, relax. The more you get the muscles to do some work, the more it will help to reinforce it. Remember, spasm needs to be reduced and controlled, because you want to superimpose contract, relax, contract, relax. So if the spasm is going to, I will call the spasm protective guarding. The brain is only trying to protect the area. So when you put the collar on, or when you support it and you contract it against it, you see your brain will release and let it do some function. But if you do any movement and there is more expulsion of the disc, then you're going to have, you feel the pain, you feel the treatment, you feel the pain. It's going to get worse because it's impinging on the nerve roots. And this time, we are talking about on the nerve root, on the nerve itself, just like you want to say. But start with shoulder and shoulder girdle movement. Okay, then you can go to turning from side to side, come to the middle, complete the range, come to the middle, complete the range. Usually don't go to the full range. Okay, start with outer, middle, and wherever you see your limitation, work on the area of that limitation. If the pain comes in, that's for the end field to movement. If I
So sorry for the technological interruption. I think there had been network issue for a bit, but it seems like he was now, totally cut off from us. Most of the questions were answered except for one in the platform, and I will get the answer. Auntie Susanna, I will get the answer to your question to you from him. Very sorry for, the technicality of the meeting tonight. Hope it was helpful that we learned some things in exercising. And that we are able to take something home in exercising. It is important that we exercise. If you can look at that segment again on YouTube, that'll be great to see, to see how it taught us the back exercises, the shoulder exercises, and, even some weightlifting. I'm seeing on the platform that, yes, it was very helpful. It indeed was very helpful. He's very passionate about physical therapy and everybody being healthy and strong, and that showed in his presentation. And I know that we are, very grateful for that. So if you have any exercise questions, sorry, I cannot answer it. I learned a lot along with you.
sorry, I'm back. The questions were getting too tough, so I ran away.
Okay.
The phone died on me.
Sorry about that.
Yeah.
I have one more question on the platform. And thank you so much for all your.
Is that okay with the?
That is okay. That is okay.
Okay.
It was a 2-minute answer, so we got like 10 minutes of that. Let me ask this next one.
I'm in trouble.
Let me ask this next one. So, Auntie Susan says, is there an advantage in going on long walks, like 3 miles, holding dumbbells, while going on the walks? And the follow-up question is, what is it and how much weight is reasonable to, carry when one is going on these long walks?
Okay, certainly that's a question I would answer from some of the things I said before. Number one, exercise principles, like we said, you don't want to go beyond 60% of your maximal oxygen intake, which I said you can determine by how much breathlessness you are feeling while you are exercising. Okay, the maximum you can go and feel so breathless is your 1 RM. Whether you quantify it in terms of distance.
We don't know what 1 RM is.
I did explain at the beginning the maximum you can do.
Okay.
And I'm going to reinforce it. The maximum you can do, if I can walk briskly, okay, that is at a pace of a normal pace is about 20 about 40 feet 40 steps in a minute. If I can go a mile before I start feeling breathless, Once I start feeling better and I can't go anymore, that this is too much. That's my 1 RM. Okay? So my 50% of that 1 RM is like to be about 50% of my distance, but it doesn't work that way. So we prefer to use your heart rate, which mirrors the physiologic work your body is doing. It's not that way because just like one of our previous person who asked the question has said, your first few feet, you're possibly just warming up. Okay? Okay? So, but when you now feel, so we call it rating of perceived exertion. In which case, if I say from 0 to 10, maxima is that I can hardly talk, okay? When I can talk moderately without getting so fatigued, that's probably going to be my 50% of my RPE, rating of perceived exertion. In which case, I'll now say that is my level 5. Okay? Then, as I continue that conditioning, most likely my level 5 will continue to increase. Even what I call my 1 RM becomes tolerable. Okay, so that determines how far you can walk. I normally tell people spend just about 60% of your energy, okay, just in case you have to return back home quickly. You don't want to get stuck. I can't go back home. Okay, so that is one. If the amount of weight you want to carry, one, the weight is carried for 2 reasons. It's going to work your cardiovascular system more and going to also work your muscles more. Okay, so if during the process of doing that, if you are a man, I've been telling them use the 5-pound weight. And because ladies are always lighter, okay, they normally use 3 to 5 pound weight. Men is about 5-pound weight. Now, the weight concept is within the next 2 to 5 minutes, the weight that is appropriate for you, you should not remember you are carrying a weight when you are working on it. Okay? If you see, if after going, you still feel like, oh my God, I can hardly pick up my leg, then that load is too much for you. Okay? So if by the time you put in, I say, oh, man, this thing it feels heavy. But you start working, and after about 100 feet or thereabout, you should forget that you add the weight on your leg. The same thing so I prefer you using an ankle cuff weight. That is the way you wrap your wrist and when you wrap around your ankle, so that it doesn't impede your movement. When you have a grip on a dumbbell, remember you are doing isometric exercises. You are increasing the tone in that muscle. You are not allowing your hand muscle to be part of that aerobic function of contract and relax. Okay, so to optimize. However, if you are also interested in improving, why I brought the mats is that rolling your exercise mat into a small roll, unfold it and roll it is your best exercise for your hands and fingers to remain in good tone. Prevent your carpal tunnel syndrome. If you even do it in the morning and at night, okay, throw your mat down and roll it, okay, and throw it back up and roll it and forward and back just 3 to 4 times. You will have worked on your wrist and finger muscles so that they have their own component of aerobic and strengthening exercise. And because there are muscles too, there are every kind of tissue all over the body, just like your heart, they are as important to the brain as much as so they have to do their portion of exercise. So that's the way I will answer it. So if you are using a weight and you are still conscious that the weight is heavy for you when you are working, then that weight is too much. But if you put a weight on and you don't feel it's heavy when you want to start, that weight is too little. So 5 pounds to 8 pounds is usually for most men. Okay, 3 to 5 pounds for most women. But can you graduate it? Definitely you can. If you are doing stair climbing, that's another story. That makes it more interesting because you are going against your body weight plus the weight you are carrying. Okay, but remember the bottom line, rating of perceived exertion. Am I feeling 20% or 40% or 80% of my maxima. And your maxima is when you cannot keep a conversation, you can't do, you should reduce your intensity, you should reduce your pace, or you should just sit down and take a rest. Okay. Now, when you walk intermittently, it all adds up. It adds up for the effect on your cardiovascular system. Okay? So it's not that you have to do a grueling, extremely sweating. So whenever you break into a sweat and you can still talk a little bit more, please walk a little bit further. Okay? But breaking into a sweat and keeping a conversational tone is an easy way to know if you are going beyond 70% of your maximum. Conditioning is 40% to 60%. If you get better condition, then you can move yourself to 60 to 70 to 80%. RP's cost of 6 is the ideal, 60% of your maximum. And we call it rating of passive exertion. That is, you are self-rating yourself. Madam, did I, because
Okay, I will just bring you back a little bit to the question. The question is, thank you, 100% on the dumbbells, the weight. She asks, is there an advantage in going on long walks, 3 miles, for instance?
I just answered it. There's
Okay.
no advantage to you if you are going to overstretch your system.
No, it's not overstretching. That's not the question. She asks, is there an advantage to walking 3 miles? This is somebody who walks 3 miles and is fine, walks it joyfully. So,
Okay.
and
Let
doesn't.
me answer the
Is
question
there an
directly.
advantage? Is it good or not? Or should one do 1 mile?
It is good for her.
Okay.
If you can do 3 miles and she's not breathless at the end of 3 miles, it's not even good enough. She should go to 3.5 miles. If she wouldn't break into sweat at 3 miles and she didn't feel breathless and she can maintain a conversation, or she can sing along when she put her iPod in her ear, that means you are not actually taxing yourself enough. Okay? Okay. But like I said, you keep yourself to 60% of 70 of your maximum so that if you need to get back home, you have some energy to go back home.
Fantastic. Okay, so I think you answered the question on the dumbbell. You answered that question, I think. If you didn't, I know Aunt Susan, she'll speak up. I think you did. Thank you. This has been very enlightening, but you have work to do. I have people asking for your practice information.
Yeah, Yomilawa knows me. Dr. Aluya knows me. We're in the same territory. I see these people almost every day. And you can get me.
Dr. Popoola, I
Yes,
have people asking for your practice information. I didn't say people who know you. There are people who don't know you on the platform and they just want to know where you work, but it's all right.
Okay, no, I'm coming. I'm going to break it down.
I'll get it.
Okay, I'm going to shoot a copy of my card in the so that you have my address completely. Miss Fatima, can you come over? Okay, I'm going to shoot a copy of my card there, and I can do telehealth with you successfully. I love to go to the man with the white beard house to do that. That's Dr. Moses.
Fantastic. Okay, now, Dr. Popoola, I have a question, and
yes,
if you please answer it in like 2 minutes. Dr. Ezugu, kindly unmute.
I want to take this.
Thank you.
Yes. Dr. Popoola, I just want to thank you for your presentation.
Prof. Cardiologist.
How are you?
You're on my side, I believe.
Oh, definitely. And I really want to re-emphasize the importance of what you're doing and the value of rehab in cardiac and many other illnesses, pulmonary. You know, these things really do well for the body and prolong life and help with illness healing. So I really do encourage that people continue to do exercise, and I support what you're doing and all those basic things you can do at home You may not even need to subscribe to going to a gym. Learn those things and do them. Okay. Thank you for your presentation.
Yeah, thank you so much, sir. Please,
Yeah.
reinforce your clients, because we are your clients on this platform, on the need for proper understanding of how to measure their pulse rate and use the equation of passive exaction, which I find even more reliable for home exercise program than pulse rate. It works with everybody successfully, so you will know when to stop yourself, okay, and when you know what you have to do a little bit more, so you can get the benefit. Thank you, Doc, sir. You're welcome always.
Please post your practice information for those who are asking, or I can, forward it, whichever works for you. But I think he has frozen. Network issue, technology again. So sorry about that. I will get his information to you. Well, if there are no other questions, we will adjourn till next week. We have an exciting person coming next week. I mean, you will be fascinated by things in our environment that we have no idea are toxic to us, and that we use every day. And we're going to discuss and dig deep into those next week. So till we see next week, please be safe. COVID is raging again. And so a slew of other things are still raging. So let's be careful, especially when we are in places where there are lots of people. So thank you so very much for making this another successful medical